Well, I'd like to thank everyone for coming out on what's supposed to be a beautiful but not yet Saturday morning, and thinking and watching the TV of our colleagues and friends in North Carolina. It's really horrible. I'd like to thank the AIM at Melanoma Foundation and Sam Guild for organizing this. I never met Sam's sister, Charlie, and someday I'm going to ask her mother why all of the girls got girl names that got shortened to boy names. Something was weird with that. I never met Sam's sister, Charlie, but we all feel her presence, and it's what Sam and her mother have accomplished is truly amazing. I can tell you that every melanoma specialist around the world knows Val and Sam Guild. They know them, they respect them, they look forward to talking to them. And we are really honored at Morristown Medical Center Atlantic Health Cancer Care to be chosen as a site for one of their meetings in 2018. I'd like to go through and talk about a wealth of data. My slides tend to be pictures, and I'll help you talk through the pictures and understand what's going on with them. Can you ask Tim if there is a laser pointer? Thank you. So it's important in today's world to give your conflicts of interest. People in the New York area know that very well. The head doctor at Sloan Kettering was fired this week because he didn't think it was important to tell people that he was on boards of directors of companies that he was talking about the data. So I am not on the board of directors of anything, but actually I'm proud to be a consultant to many different companies in the melanoma landscape because honestly that means that you're relevant and they care what you think. So you can look it up, and I'm proud of it, and here they are. What is melanoma? I don't want to get into it too much, but basically it's a cancer that arises from the pigmented cells of the skin primarily. It can occur in the mucosa, in the mouth, in the vagina. It can also be in the eye. Those are different cancers. It is not the most common skin cancer, but as you can see up here, basically 180,000 people in the United States in this year will be told one way or the other that they have the word melanoma associated with their name. Now, half of them are going to have melanoma in situ, which is very low risk and doesn't spread and is always curable. And of the 90,000 or so that get invasive melanoma, the odds are stacked for them, believe it or not, as we sit here talking about metastatic melanoma on a Saturday morning, because about 80 to 85% of all melanomas diagnosed, even when they're invasive, are very low risk and basically curable by surgery. I think we all kind of know the warning signs at this point, the A, B, C, D, E's. We don't laugh at them, but they're kind of old hat at this point. But I can tell you one of my first melanoma patients in my career was driving down the highway with his elbow out in his pickup truck. And he listened to a public service announcement because it was May, which is melanoma month. And we were talking about the ABCDs of melanoma, and he went, and he pulled off and went to the emergency room because there was a big H sign, and ended up having melanoma, unfortunately for him. So that thing works. But before we got to the 21st century, and we're already 18 years into it, there were some things that were really true about melanoma all the time. So the primary treatment is surgery, and that's why 3 of the 4 speakers this morning are surgeons. That's how almost everyone with melanoma gets treated. And as I said in the last slide, for just about everybody, believe it or not, surgery is curable. Now, if it spreads to the lymph nodes, it used to be, and Kai is too young. Kai is too young to remember. But in the 1990s, we used to sit there and have long arguments about who should get the lymph node dissection. This is before sentinel nodes. Who should get all the lymph nodes removed? Which lymph nodes should be removed? Does it matter if you take out the level 2 or 3 or how many you take out? People argued about this endlessly. It was really parsing data, and there was a lot of clinical trials around it. And until sentinel nodes came out, that's what people did. And if you had a positive sentinel node, as Dr. Bickenbach said, you got the rest of the nodes taken out. It didn't matter if, the melanoma was just in one little cell. It didn't matter if it was just in the PCR, just in the DNA of the cells. If there was any melanoma lymph nodes, you had the second surgery. Bang, we're doing it next week. And I'm reminded of that actually occasionally. Many of you know I used to be in St. Louis, Missouri, and every once in a while a patient that I did a lymph node dissection on from the 1990s calls and says, hey, just wanted to let you know I'm still around. Thank you. And I think, I'm glad you're still around, and if we saw you today, we wouldn't have done all that surgery, but it's okay, because everyone's happy you're still around. We also knew back in the 90s that if you had distant metastatic disease, if there was in the lung, just an isolated spot, and you took it out, for whatever reason, with melanoma, there are some people where they did great. And radiation and chemo didn't work. It was just a truism. There were 2 approved chemos for melanoma. They're still approved. No one uses them. They didn't work very well. And radiation only seemed to work in isolated instances, honestly, in the brain. And finally, and this is up until very, very recently, if you looked up in any textbook of cancer, if melanoma is metastatic, what is the average survival? It's 5 to 9 months. That was it. You could fit all the melanoma specialists in the world in the first 4 rows of this auditorium. We all knew each other because we were the nuts. We were the people who thought hope against hope that someday we'd be able to talk about cancer treatments that work for our cancer too, and that we'd figure out why chemo didn't work and why people just didn't do well. And one of the big hopes, and the reason why almost all of us got into the melanoma world, was the fact that for alone among cancers, melanoma responded to immune therapy. There was a reported incidence of people who had spontaneous regression of all their melanoma for no apparent reason, and the only possible explanation that people could come up with was that their immune system somehow had figured out that the melanoma was bad and it was going to kill it. And it went away. And this dates back to the 1960s. And actually, there's stuff from tumor vaccines back in the 1920s and 30s where the immune system figured it out and the melanoma all went away. And we all hung our hat on that. Someday, we're going to figure out why and how that the immune system might work. And based on that, and this is from a review in 1999, interleukin-2 was approved. I don't know if any of you ever received interleukin-2, but it's nasty. It is the only drug approved in the world for cancer treatment that is dosed to toxicity, which means no one knows how much you're going to get when you start. We give it to you until you get so sick that we can't give you any more. Think about that one. But that was approved in 1998, and it was based on this data, and I'll explain that data in a second. There's more evidence of the fact that the immune system helped treat melanoma, and that was another drug approval called interferon alpha-2b, which was approved to treat people with lymph node spread of melanoma based on this data, which is from 1995. It was published in January 96 and approved in December 95. For some reason, those dates stick in my head. Most days I can remember what my kids' birthdays are, but this I remember. And when you see these curves, you realize that there's not a lot of difference, and I'll explain that in a second. But this was approved. And for years, that was it. We had interleukin-2 and interferon alpha, not really great. And then we started developing something called the immune checkpoints, and this is from Dr. Wolchuk at Sloan Kettering. He used to show this slide before anyone knew what immune checkpoints meant, and before anyone had coined the phrase, actually. So what he meant was that the immune system can recognize things through a receptor-antigen complex, the T cell, the lymphocyte. And there are some interactions, for the sake of argument, basic level, we'll call it CD28B7, which make that immune system work better. So it's like the accelerator pedal in a car. But then there's converse reactions, which at that point, all we knew about was CTLA-4, which actually puts the brakes on the immune system. And this ends up being the low-hanging fruit, if you will, of how the immune system can actually attack and kill cancer. So I need to back up, and some of you may have seen this part of my talk, and I'll whip through it. How do we as doctors evaluate this data? We don't just magically make slides in our heads. We actually have to read the papers and look at the data. So this is called a survival curve. Survival curve is over time, how much of something goes away. Everything starts at 100%, whether it's alive or dead, whether or not things have recurred, whether or not it's come back distantly. At the time zero, it hasn't happened to anybody, or everyone's alive. And over time, unfortunately, with cancer, or if you look at Medicare patients or anything, less people are alive. And this is the compendium of interleukin-2 treatments when it was approved, showing that over time, 90% of people who got interleukin-2 died. Not very good. And this goes out to over 10, this is 10 years right here. So when we talk about median survival, that means what point are 50% of the people alive? And that's right here, and that drops down to just under a year, just over 10 months. So that's even with interleukin-2, not very good. Now, the math behind this is called a Kaplan-Meier curve. I was a math geek a long time ago. I don't understand that equation, but that's okay. Someone does, and now we have computers to do it. So we get to, this is something that didn't exist until around 2009. This is called a waterfall plot. A waterfall plot is showing you what happens to the size of the tumor in individual patients. Each bar on this plot is either going up or down. If it goes up from the line across the middle, that means the cancer unfortunately grew. If it goes down, that means the cancer shrunk down to 100%. Waterfall plots look great when most of the people respond. Unfortunately, before 2009, most of the people were going up with melanoma. But now we had to come up with a cool name for it, and we call it a waterfall plot. So when you see these things from now on, you'll think, Whitman, waterfall plot. And I'll have made a difference. This is a spider plot because of all the legs. Every line here is one person who got treated with any kind of treatment for cancer. They start at 0, which means that the cancer hasn't changed at all. If the line goes up, unfortunately, cancer grew. If the line goes down, the cancer shrunk, and we're all happy. And this is over time. Why do we do spider plots? Why don't we just do waterfall plots? The answer is actually pretty simple. With immunotherapy, sometimes, look at this curve, the cancer grows and then it shrinks. You never see that with chemotherapy. You never see that with most treatments. You see that with immunotherapy because sometimes it takes a little while for the immune system to kick in. And therefore, we have things called spider plots. You guys are going to be looking for this in the New York Times, and they just don't show it, but that's okay. This is called a swimmer's plot. Anyone have kids that swim? And they swim laps, back and forth, back and forth. We had 2 children. My wife and I were so thankful that neither one of them wanted to swim on a team. Because you wake up at 4 a.m. and you watch them go back and forth and back and forth. Instead, we woke up at 4 a.m. and we watched them go back and forth on ice playing hockey. It's a different story. A swimmer's plot is used to show how long the treatment works. So over time, for each patient, the bar represents how long they were responding to the treatment. The diamond here, can't see it's a diamond, but it's a diamond, trust me, is when people first recorded that the cancers were shrinking. But over here is how long it actually lasted. And if you can see, it doesn't project well. If there are little arrows, that means it's still lasting. They're still swimming laps. So the swimmer's plot just means, okay, you got the treatment and you responded. How long is it going on? And honestly, thankfully, I look out over in the audience and I recognize a number of people who are still with the arrow out there. And they're shaking their head at me, yes. And we're all happy. Here's the final one. This is called a forest plot. Forest in the trees, right? The dotted line in the forest plot, it compares 2 groups. And this is just a breast cancer trial. It doesn't matter which one. It's breast cancer. We don't care about breast cancer. I'm sorry, we don't care about breast cancer as scientists. We care about breast cancer, of course. So you have the dotted line. Anything to the left favors the experimental drug. Anything to the right favors the other thing you do, whether it's placebo or standard care. And so each line is a different data point. How long have they had breast cancer? How old are they? What kind of breast cancer? Things like that. And the bar represents how people did in that group. And then the big box is the median. So if the box is to the left, that means that people who are, let's say, if they've, what's a good example? Here we go. If they've had DCIS for less than 10 years, then they tend to do better. But if they have had DCIS for more than 10 years, they're still doing better, but it's close, because the dotted line means there's no benefit one way or the other. So to summarize, survival curves show you how long things last, and it's always relevant. You always want to know how long people live. A waterfall plot shows you how many people respond and how much. Does this go up a lot? Does it go down a lot? Does it go down a little bit? And it's great for drugs that are really active. The spider plot shows you for each person what changes over time. And it's great for something like immunotherapy where things may not go up or down right away. They may change over time. And the swimmer's plot tells you how long things last, which is especially important in today's world, because we don't want to give a drug and have it go away in a month. We hope to have a drug that lasts for a really long time, and there are differences. And then the forest plot tells us who benefits from the drug by group. So let's continue our melanoma story. This is Dr. Allison. There's a couple interesting things about this picture. The first is that I've never seen him with his hair combed. Okay? This is a faculty photo on the website of MD Anderson in Houston. Never seen him with his hair combed. Second of all, he got a haircut for this photo, because his hair is generally down below his shoulder. He's an incredibly bright guy, and mark this picture down. In our lifetimes, he will be in Oslo getting a Nobel Prize, wherever you go for it. In 1994, I published a paper that everyone kind of, okay, whatever. He identified something that was called CTLA-4, and he figured out that if you blocked CTLA-4, the immune system worked better, and in mice anyway, the cancer got killed. So the cancer was surviving. If you gave this, I'm just paraphrasing, if you gave the CTLA-4 antibody, if you blocked it, then the treatment you were giving could work, and the cancer died. And the resulting antibodies that were developed in that lab, one of them is now FDA approved, Ipilimumab, to treat melanoma and renal cell cancer. And it's really amazing what he's been able to accomplish, and if you do a literature search on him, he's still actively publishing. He's at every major meeting. But when he comes out at major meetings, his hair is uncombed down below his shoulders, and he's wearing sandals while the idiots like me are sitting there in suit and tie. That's the benefit of being a genius. What does that mean in terms of immune checkpoint inhibitors? The basic principle is that our immune system wants to kill the cancer, but the cancer has figured out how to hide. The cancer has figured out that if we do certain things, if we evolve to show certain proteins on our surface, we block the immune system from being effective. And we call those checkpoints. And if you think about it, it prevents us from all getting autoimmune disease. But from a cancer treatment perspective, and what's revolutionized things, if this is the normal interaction right here, if the interaction shows that the B7 and PD-1 are interacting in addition to the T-cell receptor and the MHC peptide, if we're showing that, if we block the PD-1, which you see over on the right picture, this killing of the cancer cell can occur. And that's the low-hanging fruit that everyone was looking for, and has been enabled by the pioneering work of Dr. Allison. But before that, it's kind of weird that this happened at the same time as the financial crisis around the world. In 2008, we hit our low point in melanoma. We can say that now in retrospect, and everything's been much better since then. But we hit the low point. And this is, unfortunately for Dr. Korn, who's a nice, very smart man, will always be attached to his name, the Korn study. The Korn study looked at every single clinical trial that the NCI, National Cancer Institute, had ever sponsored in melanoma. Every chemotherapy trial, every other trial. And they combined all the data into a huge database, so it's called a meta-analysis. And they said, how did people do in all those trials, 45 different trials, 42 trials, 70 different clinical trial arms. Let's try this, let's try that. Let's combine these drugs. How do they do? So here's your survival curve on the left. Median overall survival, 6 months. This curve on the right is a little different. This shows you what is the 1-year survival by trial size. And it again tells you the problem here. And that is that as you look at this, that's 60% survival. They're all in there, and that's 0% survival. All the trials grouped into the same area, they all were abysmal. And we all sat there at meetings that entire year just going, ugh, we're not getting anywhere. But the world got better. Starting in 2011, there have been probably, this was in 2015 when this was published, but there have been an enormous number of huge trials that have been published and data has been published and clinical drug approvals. Many of you in the audience, both here and around the world on the internet, so cool, have benefited from those drugs, I hope. They don't work for everybody, though, and we have much further to go. In 2018, this is a laundry list of all the different cancers that have checkpoint inhibitors approved for them. It's not just melanoma anymore, and it's changing even in 2018. Renal cell, different lung cancers. There's even an approval for a drug that is used to treat any cancer from any organ if it has certain genetic changes. Truly amazing changes just over the last few years. And as we look at what we understand about the immuno-oncology cycle, and by the way, the word immuno-oncology did not exist in 2008. I'm not sure who will ever get credit for making it up and dragging those two words together, but I can tell you at cancer meetings, everyone talks about IO therapy, and they mean immuno-oncology therapy. So now you can walk out of this meeting and you can say, I learned about IO therapy for cancer, and you're there. You got it. So where are the 7 areas that we think that IO therapy can matter? And we start down here, lower left. If we can get the cancer cells to release the right stuff, the right chemicals, we have a chance. If they'll release chemicals that the rest of our body can recognize and attack, we got a chance. But it's more than just releasing them. They have to be presented. Our immune system Our immune system presents the antigen. They have to be presented correctly. If you only use one hand, the immune system can't recognize it. That's the analogy, sorry. If you use 2 and do it right, it's okay. If you do it like that, it doesn't work. So it has to be presented correctly. Third, the recognition has to be acknowledged by the immune system. It has to prime and activate white blood cells. The white blood cells then have to find the melanoma or other cancers. They have to go there. It's not enough to just be floating around endlessly. They have to be able to find the melanoma cancer. And I'll tell you where that's relevant. Pancreatic cancer. There's something about the pancreas that creates a moat. That even if you're able to recognize it in the immune system, there's something about the pancreas and the blood supply that we don't understand, or the way the pancreas is structured, that it prevents the immune system from getting there. There's a moat, so it has to be able to traffic there. Once it gets there, it has to be able to get into the cells. Again, it can't be protected by a wall or stroma or any other sort of thing. And then finally, it's got to recognize it and say, aha, to get to step 7, kill. Like Fortnite, right? What am I talking about? What is Fortnite? I don't know. So what's approved for melanoma? The first, thanks to Dr. Allison, the first drug approved in 2011, March 2011, was Ipilimumab, and it's based on what we call the tail of the curve. 10% of the people who got Ipilimumab responded. That is, their tumor shrunk. but 20% of them are alive at 5 or 6 years. What does that tell you? You don't necessarily have to have your cancer shrink to respond. It changes how we think about it. It's not just about the fact that the cancer gets smaller. Maybe it just kind of equilibrates with your immune system. Maybe there's a give and take that it can't spread and you can't kill it directly, but you know what? It's okay. It's not great, but it's a lot better than what it used to be. And the tail of the curve is everything for immunotherapy. Some of the next drugs that were approved were nivolumab. Here's a survival curve, remember? And it shows survival over time. And you can see that the blue curve, which is nivolumab, these are metastatic melanoma patients, compared to the old-fashioned chemotherapy, which doesn't work, right? These people were alive longer, and you get that tail of the curve. And by the way, the only reason this is so high, this curve, is that this happened in 2014 when there were other drugs approved. So if they failed chemotherapy, they got the other stuff. And what does that mean? I'm sorry if this doesn't make sense to everybody. The better we get at treating any cancer, the harder it is to prove that the next generation of drugs works, because the bar keeps getting raised. And it's harder to show that it's better. Here's a different way of looking at pembrolizumab, which is similar to nivolumab. This is the waterfall plot. You can see that the majority of patients, the cancer shrunk. And look at all these arrows to the right. That means that basically for almost everyone whose cancer shrunk up here, when they were assessed for the clinical trial, it was still working. Things were still small. They were still shrinking. Now, what about combining the Ipilimumab, the anti-CTLA-4, and nivolumab, the anti-PD-1? This is a spider plot. You see that concentration of lines? This was the first data with that combination. That's dramatic. Almost all the people in that first trial, and again, it doesn't work for everybody, and this might have been a highly selected group, but almost everyone in that first trial, very, very quickly, 2 to 3 months, things went boom, shrunk. Everyone saw that and everyone's eyes popped. That was at ASCO. But does it really improve survival relative to things that shrink slowly? This is data just from this year. Maybe not. If you look over here, this is the Ipilimumab alone arm, and here's combination, and here's nivolumab alone. And what you can see is that ultimately, maybe there'll be a difference in survival, maybe not. And again, the bar keeps getting raised, because when it was just this bar, it was a lot easier to show a benefit. What happens when you stop therapy? Many of you in the room ask me that all the time. I stop, what's going to happen? And this was just presented this June. These are patients who stopped getting treated with pembrolizumab, an anti-PD-1, who had metastatic melanoma, followed over time. This is out to about 2 years. What percentage of them did not progress? What percentage of them did the cancer not grow? So if you're at 100%, if you stay at 100%, that means your cancer did not grow. And here we see that over 80% of the people who stopped treatment did not progress over a 2-year time. That's really encouraging, exciting. And that's what we want to, this is a different way of showing what we're already suspecting, which we call the tail of the curve. Many of you in the room and listening, and I'm sure, are familiar with some of the myriad side effects. And what I always tell people is, first of all, anything weird that happens to you on these drugs is probably from the drug. And second of all, I don't know when it's going to happen. It's not like giving chemotherapy and it happens and it goes away, or it happens over time and then it slows down. So the time course is very, very unpredictable. But I don't want to make this talk about the side effects. There's also another approved therapy, which is called Talimogene Laherparapevec. You like that? I was in a meeting once and someone said that, and I said, teach me how to say that, because that's a hard drug to say. And I realized right there that when you work for a drug company, you get trained in how to pronounce the drug names. So it just rolls off the tongue. And then the second thing I learned was that company got sold to a different company, and they say it differently. But Talimogene Laherparapevec is how I was taught it, and I'm not going to try and learn the new way. And this is a recombinant virus that is injected into tumors. And remember that cycle we had? It kills the tumor cells and causes the antigens to be released. And the question is, will they be presented correctly? Will the immune system be able to recognize them and find them and kill them? And in fact, as you see in the lower right-hand corner, sometimes they do. And that's approved. What about targeted therapy? This is the enzymatic pathway for melanoma and a lot of cancers to grow. And there's a lot of fancy little enzymatic names that people have to memorize in medical school, and then we all try and forget them as quickly as we can. But the important one here is called BRAF, B-R-A-F. And you can see, based on something that happens on the surface of the cell, the BRAF is involved ultimately in the cancer cell growing and dividing. And it was noted right around the time of the financial crisis that about 40% of melanomas have a BRAF or BRAF mutation. And this is the phase 1 data when people developed a drug that blocked the BRAF mutation. Didn't do anything to regular BRAF melanomas. You can only take this if you have a BRAF mutation, but you can see, look at that waterfall plot. That's impressive. Over 90% of the people, things are getting smaller. And that was really exciting. That was presented in 2009, and the room went silent. Look at what we were able to accomplish. But the problem is with these drugs that over time, the cancers are too smart. If you go out to the highway today and there's an accident, everyone figures out eventually how to get around it, right? Either they wait in line and it slows down, or they go out, they get an exit, or what's it called, Waze takes you around the way. Cancers do the same thing. They figure out a way. And there's about 5 or 6 different ways that the cancers can get around our attempts to block a BRAF mutation. And in most, but not all, and we don't understand why, in most, but not all cases, eventually the cancer figures it out. Now, if we combine it with a MEK inhibitor, which is the next enzyme down, if we combine it with a MEK inhibitor, it actually works better. And here's your survival curve showing that. The blue line is the combination. The orange line is single drug. And here's the latest. This is just published and approved this year. And this is now the standard of, this is now the best data we have on these combination therapies. We don't know if one's different than the other, honestly, but we now know that on average, people who get this combination therapy for BRAF mutated melanoma will live, on average, again, half the people live longer, almost 3 years. Again, think back to 1999. 70% of people were dead in a year. And now we have people living over 3 years. So what's new in our last few minutes? A couple things to think about. One is that adjuvant therapy, and Dr. Bickenbach was referring to that. Adjuvant therapy comes of age. Someone asked me, what do these new trials mean that you'll see? What does it mean to have these new drugs that are approved for adjuvant therapy of stage 3 melanoma? And my little soundbite was, I still like it, for the first time in my career, I can walk into someone's room, in an exam room, who has stage 3 melanoma and happily tell them in an excited way that there is a great treatment that's going to help them and not have to hedge. Well, there's a treatment, it's got a lot of side effects, I don't know if it's going to work, it doesn't improve this, it doesn't improve that, but it's better than nothing. No. We have approved therapies that are better than doing nothing, that improve survival, that do not come with an unbelievable load of toxicity. So here's the first one. This has significant toxicity, but this was approved several years ago. And again, you can see a survival curve where the blue line is above the orange line. That means that more people live. And this is high-dose ipilimumab in resected stage 3, stage 4 melanoma. And people did better, and this was good, but it was fairly toxic. And just a year ago, just last September, almost to the day, this was published and presented. And this shows ipilimumab on the lower bar. And remember I said the bar got raised. And this is adjuvant therapy with nivolumab. Survival curve. More people live longer, and you have the tail of the curve, better than ipilimumab. This was what got us all excited. And then it was followed by the fact that if you have BRAF mutated melanoma, and by the way, we don't know if it's better to be treated with the targeted therapy, immunotherapy. That's another 3-hour talk, so we won't go there. But relative to doing nothing in stage 3 melanoma, if you have BRAF mutated melanoma, here's your survival curve, you clearly live longer if you get the targeted therapy. Very exciting stuff. And here's your forest plot. This is for the BRAF/MEK inhibitor therapy. There's that dotted line. Anything to the right means that people did better by doing nothing. There's nothing there. Everybody did way better. The further you are to the left, not just the dot, but the bar with the hashes on either side, the further you are to the left, the better people did. It didn't matter, old, young, didn't matter. Where the melanoma was, anything else, any piece of data they could look at, everyone did better with that therapy. We have made huge advances from 2008. This was published last week, 2 weeks ago. Time's flying. Unfortunately, about a third of people who have melanoma will have the melanoma spread to the brain. And for years now, it's been treated primarily with radiation. However, as you can see here, this was published in New England Journal of Medicine. This is only 94 patients, but it's still a fairly large group. And the most interesting thing here is in the response rate right here, percent of patients. Inside the brain, intracranial. And these are people who did not get radiation. They got combination Ipilimumab and Nivolumab. Remember that spider plot where everything plunged down? We didn't know. People talk about the blood-brain barrier. We didn't know if that crossed into the brain, if it would work on the brain. And this is the largest study to date, and this is prospective study, not randomized. 55% of people had the melanoma in their brain without radiation shrink with the treatment. I'd say it crossed the blood-brain barrier. Here's the amazing thing. That is basically the exact same percentage of people who had the melanoma shrink outside their brain. I think this is the first time in the history of cancer treatment that giving a cancer therapy has shown the same really big benefit inside the brain, outside the brain. This is huge. This paper has defined and changed melanoma treatment for people who have melanoma that spreads to the brain. There's your swimmer's plot. Not only did it work, everybody's got arrows. It's still working. And here's your survival curve. It's unbelievable to the people in the melanoma world that now we have this curve showing that people who have melanoma that has spread to the brain, now it's not a long-term curve, but at 2 years, 80-some% of them are alive. Unbelievable. Fantastic. So I want to talk about a couple of things. I'll go to biomarkers. We're almost done. Somehow in my career, I always knew my life would be about poop. That was even before I had babies in the house. So those of you who don't know, the microbiome is a fancy word for measuring the bacteria in our poop. It's a big deal right now. As it turns out, poop matters. Who would have thought? And what's in your poop matters. And people are looking at the bacteria in our poop and whether or not it changes your ability to respond to various drugs, specifically immunotherapy. And you go to the next quantum leap from that is, okay, if I need more of that type of bacteria in my poop to respond, let me have it, right? How do I get more of that bacteria in my poop? Now, this is all preliminary. No one knows yet what the right mix is, but people are looking at it. And you can actually buy, if you want to, freeze-dried poop and eat it. It's in plastic baggies. You don't taste it. This is just a representation of the fact that this is coming. People are looking at this. People are showing differences in survival, but moreover, not survival yet, but really response to immunotherapy based on what is in your poop. Some of you may have had a DecisionDx melanoma test. We're not there yet, but this is a sort of genetic test that can help to show us melanoma-specific survival. If you have a different score on this, nothing else being taken into account, it looks like you may do better or worse. And this may affect treatment in two ways. First of all, if everything looks good, if you get surgery and we're worried about you because of your decision DX score, maybe we follow you and you follow us more closely. Because some of you everyone in the room are listening to me, this does not apply to, okay? Because everyone in the room is here on a Saturday morning where there's a hint of sunshine, supposedly, and you have better things to be doing, perhaps. So you're all interested and motivated. But I can tell you that probably at least half of the people that I operate with melanoma who I would like to have come back and see me don't want to be anywhere near my office. And I don't blame them, I get it. But they don't want to be there because they don't want to be reminded of it. They don't want to think about it anymore. They want to say, I'm done. I had my surgery and I'm done. And the hope of this test, and I don't think it's there yet necessarily, is that at some point we can say to people, you know what, you are done. See ya. But you, on the other hand, over here, sorry, I don't mean to talk right, left. There's no one over there. You over there, you need to keep coming because we don't know where, but the melanoma could be hiding. This is one last interesting thing on biomarker, and we'll get to something I wanted to cover quickly. This is a combination of Ipilimumab and Nivolumab, and it's stratified by a biomarker called PD-L1. I don't need to go into what it is. You see how on the left, the upper curves are together, and on the right, the upper curves are separated. One possible conclusion of this is that this biomarker may tell us who needs to get the combination treatment and who doesn't. Because when they're positive, the curves are tracking together. So maybe you don't need the combination treatment. Again, future tense, not there yet. I will not go through what Dr. Bickenbach said again, except to say that the trend is away from lymph node surgery because this is the first survival curve I've shown you with no difference. And it's surgery versus no surgery. Kind of talked about that. I have to go into that. And then this is a treatment where the lymphocytes are removed, they're changed, they're grown, and given back to the patient. And this is really what you may read about in the news called CAR-T. CAR-T meaning we take lymphocytes out, we mix them up, and we give them back to cancer patients. Now approved for some forms of leukemia and lymphoma. And we're proud to say we found out this week we will be one of the next research sites for the next generation at Morristown. So I want to leave you with a thought. And it's a different way of thinking about cancer treatment, and I'm pretty sure none of you have thought of it this way, perhaps. And so there was a recent paper called Optimizing Cancer Treatment Using Game Theory. Again, I was a math geek a long time ago, but I do not pretend to understand the mathematics in this paper. But they refer to cancer as a Stackelberg game. A Stackelberg game is something that's taught in business school. It's an economics game. It means that one person, let's say Macy's, is the first mover. And they have the power to make the first move. And everyone else in the game can't make a move until Macy's makes a move. And then they respond. But Macy's is still the first mover. Macy's can still respond. But guess what happened to Macy's? Amazon came along in '95. Macy's made the first move, Amazon did it better, and Macy's didn't respond. So in a Stackelberg game, one person is the leader who can make a decision and has the, quote, power of commitment, can do something, but the other player has to wait. I'm the Stackelberg leader. My wife right now is going, oh, what a big mouth. I figure it with your help. I figure it out, and I choose the therapy. Cancer has to wait for me. Cancer's happily growing, right? They don't know about me. They don't care about me. The cancer's passive. The cancer responds to what I do. In the game parlance, in Vegas, the cancer's a stooge, right? The cancer's a setup. The cancer should be an easy win, a rube, because it's stupid, because it can't do anything except in response to what I do. It's just sitting there. But everyone wins their race occasionally. Just because cancer's stupid doesn't mean it's not effective. Just because it can't initiate something except in response to me doesn't mean it's not really good at what it does. So how are we going to outsmart that? How are we going to win the game, right? So it's a very interesting article, and the conclusion is unfortunate. How is cancer treated usually? Okay, you have cancer, you go to the oncologist, this is what you're going to get treated with. We're going to give you 4 cycles of this and see how you do. We're going to scan you. I've done the same thing. We're going to give you this treatment and give it to you until you progress. That's how every single cancer treatment regimen is designed and tested. We will test you with this drug that we have determined which dose we can give you safely and kind of effectively. We will give it to you until either the cancer progresses, in other words, it doesn't work, and we know it doesn't work, or you say no more, or you can't take any more. Those are the 3 options, or unfortunately you die. That's how every trial is designed, and it's wrong. Why? Because we don't know what the cancer's doing to respond to us. We're not trying to anticipate or figure out what the cancer has done to make our treatments ineffective. We're just writing a script. Do it. So we keep going. The cancer's trying to figure it out and survive. We're still going with our regimen, our predefined regimen. We're still going with maximally tolerated dose and dose-limiting toxicity. Those are those little initials there. We're, in the game theory world, we are ignoring the evolutionary dynamics of the cancer. And therefore, we've become the follower. We went from being the leader to the follower in one treatment, because we're not trying to think ahead. The cancer's reacting, and we're just like, you're going to lose. So this is one example of the way people are doing this with prostate cancer. I am not a prostate cancer oncologist, as you all know, so I can't comment further on this. But what they're proposing is that instead of just giving hormone therapy for prostate cancer, they are pausing occasionally. And by pausing, they allow the hormone-sensitive prostate cancer to overcome and overgrow past the stuff that's not. Because for whatever reason, the hormone-resistant prostate cancer is not as good at growing as the hormone-sensitive. But if you kill all the hormone-sensitive too quickly, the hormone-resistant grows out. So we're fooling the cancer, and we're intentionally letting the hormone-sensitive cancer win just a little bit, so we kill it better later. And by modeling it, the blue means that the hormone-resistant cancer has just overtaken the whole thing, and it's bigger. And here, again, in theory, hypothetically, by doing it that way, we've changed the game. So hypothetical, how can we change cancer care to win the game more often? We should be understanding how the cancer evolves. We should be doing genetic testing. Don't take a picture until it's done, because it's a good slide. All right? You like this? We should be able to monitor it. And again, hypothetical, it's not here in 2018. We should be able to monitor what the cancer is doing in response to what we're doing so we can outsmart it. We should vary our treatments. Maybe it's not the right thing to give 1 straight year of nivolumab. Maybe we should be giving nivolumab for a couple months and switching to something else and then back and forth. I don't know. And I won't know until we figure out a better way to monitor it. And again, a touchy subject, but should we intentionally let certain types of the cancer grow so they'll be more effective down the road, and they'll take resources away from the cancers we can't treat? I'm sorry. You want to take a picture now? I really thank you for coming this morning, and I went, I think, 5 minutes over. It's an exciting world we live in. There's a lot of stuff going on. It's positive. It's great for you all to come out. If you go on clinicaltrials.gov, which I did recently, 394 clinical trials actively recruiting for melanoma patients, 259 in the United States. 198 involve a combination of some sort. That's where the science is going. And it's almost all in skin melanoma because only 24 are in uveal. So with that, I want to give you one last thought. This is not my curve. This shows the evolution of survival curves in melanoma. Over time, how much people are alive. This is the original approval of anti-CTLA-4 for metastatic melanoma. 20% long-term survival, nice tail of the curve. And then it starts jumping up with all the BRAFIMEK approvals and the Nivolumab and Pembrolizumab approval. And up in here is the latest survival curves. And that's the combination of Nivolumab and Ipilimumab. So exciting stuff, you know, but it's not exciting enough. There's this big black area up here. But I want to put one last curve on this thing. And this was courtesy of my Photoshop skills, because after all, I am the tech support person. That's IL-2. That's the IL-2 survival curve from the review in 1999 after it was approved. Isn't this great? Some people live a long time. We've come a long way. Thank you very much for being out this morning.